Good afternoon, and thank you for joining today's COVID-19 in the Liver in North America, Impact of Contrasting Healthcare Systems webinar. And today we have something a little different. This is a collaboration between the American Association for the Study of Liver Disease, the Mexican Association of Hepatology, and the Canadian Association for the Study of the Liver. My name is Jordan Feld, and I'm pleased to be moderating today's webinar along with Dr. Jennifer Price and Dr. Ignacio Isa. And today's webinar is being recorded and will be made available on the AASLD website and through Liver Learning. Today's agenda: we will first introduce our moderators and presenters, and then we're going to have a presentation on the situation of COVID-19 in Canada, the situation in Mexico, and then the American public health response to COVID-19. And following that, we'll have a Q&A and panel discussion with the moderators and the presenters. And we'd welcome you to submit your Q&A throughout the presentation using the Q&A box rather than the chat. So just to highlight that, to use the, as highlighted here, you can see to use the Q&A function to type in your questions at any time during the webinar, which is at the top or bottom of your screen. And the questions will be answered at the end of the presentations during the moderated discussion. So here is, as I said, I'm Jordan Feld from the University of Toronto in Canada, and currently the president of the Canadian Association for the Study of the Liver. And co-moderating with me today is Dr. Ignacio Isa, who is the director of the Clinic for Liver Diseases in the Hospital Angeles Lomas in Mexico City, Mexico, and he's the director of international relations for the the Mexican Association for Hepatology. And as well, Jennifer Price, who's an associate professor of medicine at the University of California, San Francisco, and the director of the UCSF Viral Hepatitis Center in San Francisco. And we're very pleased to have our three speakers today, who I will introduce now. First, we'll start with Kelly Burak, who is a professor of medicine and oncology and the associate dean for continuing medical education and professional development at the University of Calgary. And Kelly's going to be talking to us about the situation in Canada. After that, we'll pass the baton to Laura Cisneros, who is a hepatologist and gastroenterologist at the Center for Liver Disease and Transplantation at the Hospital San Jose Tech Salud in Monterrey, Mexico, and she's the current president of the Mexican Association for the Study of the Liver. And finally, we'll turn it over to Brett Fortune, who is an associate professor of medicine at the Center for Liver Disease and Transplantation at Weill Cornell Medicine, a New York Presbyterian Hospital, and he'll talk to us about the public health response to the COVID situation in the United States. And again, a reminder to submit your questions as we go along. And with no further ado, I will start with a poll question just to get a sense of where everyone is coming from. So this question has three parts, and we'd ask you to answer all three, just to let us know which country you're joining us from, in what type of setting you work, and what is your primary role. So take a moment to answer those questions, please. All right, and so if we look at the results from that, nice to see a bit of a mix from across North America, and I expect that we will have more people joining as time goes on, and we also see a bit of a mix of practice type as well. So with that, I'm going to hand it over to Kelly Burak to tell us about the situation of COVID-19 in Canada. Kelly.
Thanks, Jordan, and thanks everybody, the organizers of ASLD, AMH, and CASTLE for this opportunity. Next slide, Jordan. Can you advance the slide, Jordan? Here we go. So thanks. I have no conflicts of interest to disclose other than the fact that early on in the pandemic, I was actually infected with COVID-19. And unlike a lot of healthcare workers, this did not happen at work. Actually, it happened on the day the World Health Organization declared the pandemic. We got together for our annual Doctors Curling Bonspiel in Edmonton, Alberta. And unfortunately, we were a super spreader event. At the time, there were only 20 cases in our province. And we were being cautious, but still about 80% of us that were at that event got infected with COVID-19. Next slide, please. So I thought I'd start by comparing our three countries geographically and population-wise. Canada is the second largest geographic landmass in the world as a country. And larger than our neighbors to the south. But we have a much smaller population, about 1/10 of that of Mexico, and about a third of the one-tenth of the United States and a third of Mexico. So how are we doing as far as COVID-19? So this is from Johns Hopkins University, and as you know, globally, we're approaching 32 million cases, and we're very soon going to reach the 1 million death mark. And Canada's fared a little bit better than our neighbors to the south as far as number of cases and number of deaths, with nearly 7 million in the United States cases and 200,000 deaths leading the way. Next slide, please. And so I thought a more fair comparison actually is to show the three countries as a 7-day rolling average of cases per million. And again, you can see here that Canada has done better than our neighbors to the south, but we are upticking right now. And as far as death goes, it's again, we have fared a little bit better than our neighbors to the south. Next slide. So this is data from earlier in the week, looking at cases across Canada, and it's important for you that who are not familiar with how our health care system is set up in our country. We have 10 provinces and 3 territories, and each is responsible for healthcare delivery. Although we have the Canada Health Act that guarantees public health care to everyone across Canada, provincial jurisdiction still applies for delivery of healthcare. And you can see that our 4 most populous provinces, British Columbia and Alberta, highlighted there, where I work in the West, and in Central Canada, Ontario and Quebec have had the vast majority of cases and the vast majority of deaths. Next slide, please. In fact, in Canada, 90% of our COVID-related deaths have happened in persons over 70 years of age, and many of these happening in long-term care. Next slide, Jordan. So we're going to contrast our healthcare systems. I thought I'd share a little bit of information about how healthcare is funded in our country and compare that to our neighbors to the south. We spend almost 12% of our GDP on healthcare, and it is increasing. And although we have a publicly funded healthcare system, about 30% of our healthcare is actually private, and most of that is related to payment for drugs, as we do not have a national pharmacare system. Next slide. So from the same report from our Canadian Institute of Health Information, comparing the 3 countries, or at least comparing Canada and the US spends a little bit more than we do per person on healthcare, and obviously much more private healthcare. And in Mexico, a much smaller percentage of the GDP is spent on healthcare, and most of that is occurring in the public setting. Next slide, please. So why has Canada done relatively well? I think one of our strengths in our country is our public healthcare system, and here in the middle is our Chief Medical Officer of Health, and on the flanked on 2 sides by Alberta and British Columbia's Chief Medical Officers of Health, and really they're highly respected. In fact, next slide, Jordan. In some ways, they almost have celebrity rock star status in our country. They're on television almost every day with briefings, and really our politicians take the advice of the public officers of health very seriously. Next slide. So when our chief medical officer of health told us that we had to flatten the curve. We had to stay at home. We did that. We shut down in mid-March. Next slide, Jordan. And the other thing in Alberta, having one provincial healthcare provider, Alberta Health Services, it really allowed us to close everything almost simultaneously. And in mid-March, we delayed and postponed all surgeries, including live donor liver transplant. We canceled all but urgent endoscopy. And in fact, by the end of the month, we had canceled all non-urgent ambulatory care, so no face-to-face. And in fact, we were doing that to increase capacity for fear what was happening in New York would happen in Canada. We built field hospitals like the one shown in this picture. But fortunately, next slide, Jordan, we did not see the big surge that other jurisdictions had, and then we started to reopen. We started to do that in May. I did an endoscopy list this morning, and we're still not fully open. We're at 90% capacity right now. And the concern is, next, Jordan, is that we are seeing an uptick in cases, and we may be seeing the beginning of a second wave. Next slide. One thing that we did when I was sitting at home recovering from COVID was think about how we're going to deal with varices without access to endoscopy. And so we really tried to maximize our use of beta blockers. And next, Jordan, as we did reopen, we had a triage system where we could prioritize patients for who was going to get access to deal with their varices by endoscopy. Next slide. The other thing that I think we've done very well is our public laboratories have really performed very well as far as testing. In Alberta, where we have a population of 4.4 million, next slide, Jordan, we've actually done now over 1 million tests in our own province. And across country, the positive rate for COVID testing is about 2.1%, well below the WHO recommendation of 5%, suggesting that we're on top of things as far as testing. But as we move into a second wave, there's still some concerns about this. Next slide. And it's not all good news. We did have the largest outbreak in North America as far as an outbreak in a slaughterhouse here in Alberta, where nearly 50% of the workers at the slaughterhouse were infected. There were 2 deaths and spread into the community. And next, in Quebec and in Ontario, there was highly publicized cases of bad outcomes in migrant laborers, many of them coming from Mexico, and in fact, some of them dying from COVID-19. Next slide. So I'm just going to end with a slide that just was on the news the other night. Over the summer, we had a doubling of cases in Canada, and over the last 2 weeks, as our schools started to reopen, we had another doubling of cases. And so next, the projections coming out of public health now are that by the end of November, we could be having 5,000 new cases a day in our country, which is quite terrifying. And next, and I think the other second wave that we have to pay attention to is what's going to happen because of deferred care, decreased screening, the isolation leading to increased mental health and addiction problems, economic loss, and we're going to have to face burnout amongst our healthcare workers as well. Next slide. So in conclusion, Canada's fared fairly well during the pandemic so far because of our strong public health care system, our access to testing and contact tracing. In our country, masks are not as political as in other jurisdictions, but it's also unmasked some issues with our long-term care, vulnerable populations, including those with first-generation Canadians with low socioeconomic class and immigrants. And it's still, we were shut down early and slow to reopen. And how are we going to deal with the backlog of care? And how is our economy going to come out of this and sustain a publicly funded healthcare system? Thanks for your attention.
Great. Thanks, Kelly, for that great overview of the situation in Canada. And we're now going to move a little bit to the south, and we're going to call on Laura to tell us how things have gone in Mexico. Laura, mic's yours.
Yes, thank you. Good afternoon. And next slide, please. These are my disclosures. Next. I'm going to talk about the epidemiology of COVID-19 in Mexico. We have, until yesterday, 700,580 total contagions, 73,697 deaths, hospitalized patient 25% and ambulatory 75%. If you can see here, the woman is 47% and 52% the men, the light red, and the range, the major range of age is from between 25 and 55 years old. Next. Next, please. The Mexican healthcare system has two different, the public hospital and the private hospitals. The public hospital includes 6 different institutions. The first one that covers the most of the population, around the 40%, is the Instituto Mexicano del Seguro Social. Next to the Secretaría de Salubridad y Asistencia, that includes very important institutions. And inside this institution is the INSABI. In the last administration was the name Seguro Popular, and it changed in this administration to INSABI. All the person that doesn't have Instituto Mexicano del Seguro Social are included in this institution. The state workers, the oil companies, and the military are included in these 3 columns. And the private hospital, 7 to 8% of the population has private insurance, and this is treated in the private hospital. Next, please. The epidemiological COVID-19 semaphore is the most of the states are now in orange color, 10 states in yellow, and only 1 in red. Next. The control policies is the use of obligatory face mask everywhere, continued hand washing and use of hand sanitizing gel, taking people temperature at every point of entry with infrared thermometer, keeping safe distance of 1.5 meters, and increase the detection using more diagnostic tests. The more diagnostic important test is the PCR test, oropharyngeal and nasopharyngeal samples, and isolation of positive cases. And it's very important to implement contact tracing. Next, please, because in Mexico, we don't have contact tracing program. Next, please. Another public policies is public event cancellation, labor environmental suspension, public transport suspension, interstate travel restriction, international travel control, and mandatory staying home. Next, please. Related to proportion of the population reporting always wearing a mask, this is a graphic of all Latin America. We are the green line. We are second to the last. There are so many people that using the mask only when they are obligated to use it, and they take it off when they don't need it. Next, please. About the diagnostic test. COVID-19 diagnostic test for 100,000 people in Latin America. You can see again that Mexico is the green line and we are in the last place. Next, please. And to rate test by 1,000 inhabitants, we can see United Kingdom, United States, and the rest of the countries of Latin America, and and again, Mexico are in the last place. Next, please. And the percentage of positive cases for diagnosis tests done in Mexico is around 60% of the tests done are positive. Next, please. What happens when you are in a public hospital and you go to a primary care service because you are a suspicious patient? They don't make a diagnostic test. They will leave for 14 days. The tests are done only in 25% of the population, mainly in hospitalized cases. It's not the same in another public hospital, the Secretaría de Salubridad y Asistencia, that they make around 2,000 tests by day using the Berlin protocol that World Health Organization recommends. If the patient needs any hospitalization for any cause, they need a PCR diagnostic test, nasopharyngeal and oropharyngeal sample. It's not the same in private hospital. All the suspicious patient has a diagnostic test and also submitted to a thorax CT scan. Next, please. About the treatment. The treatment has 8 categories, ordinary scale, they make a triage, and the first 3 points, they don't need to be hospitalized. They are treated at home, ambulatory. But from 4 to 8, they need be hospitalized and they need supplementary oxygen. And sometimes they need invasive ventilation or extracorporeal membrane oxygenation treated in ICU units. Next, please. The In this graphic, we can show the different treatment in the different institutions. These are public and these are private. Next, please. Mortality rate. In a private hospital, the 60 to 70% of the morbidity is associated to obesity. And in the rest of Mexico is first hypertension, diabetes, obesity, and smokers. Next, please. The daily deaths in patient diagnosis with COVID-19, the first country is United States, the second is India, the third Brazil, and we are ranked in the fourth, is 516 patient daily deaths. Next, please. We are in rank 10 in the world population, and we are ranking the 4% of COVID-19 deaths. Next, please. And if we see the percentage of hospitalized COVID-19 patients who died, we can see here that the first place is the Instituto Mexicano del Seguro Social, where 40 to 50% of the population died. It's important to remark that only the very ill patients are hospitalized in this institution. These other institutions are also public, and they have around 10 to 20% of mortality. And in private, we have 80 to 10%. Next, please. Why these disparities in liver health exacerbated by COVID-19 pandemic? Because delay in the diagnosis, the decreased access, and the delay or lack of treatment. Next, please. It's important to notice that Mexico is ranked in the 10th place. The last census talked about 127 million people, and this is the 10th place. Next, please. And we have the percentage of population who reside in urban, rural, and remote areas. We have 51 in rural areas and 49 in urban. Next, please. Here we can see that 6% of the population also live in remote areas. Next, please. And if we add the indigenous population, that is 14% in Mexico, next, please. You have so many people that live in remote areas and doesn't have opportunity to easy care, primary care service. Next, please. We don't have all the data for COVID-19 in Mexico associated with liver disease, but we have the result of the private hospital where I work, Hospital San Jose Tech Salud in Monterrey, Nuevo León, is a private hospital, academic hospital, and they attend 1,300 COVID-19 patients from March to September. 122 patients with a normal liver function test. Underlying chronic liver disease in 31, hepatic dysfunction with normal liver enzymes when admitted 91, and 112 patient increase of ALT, AST, or AP after use of antiviral therapy. It was a DILI, it's secondary to DILI. Next, please. There are another data for the hybrid hospital from the Instituto Mexicano del Seguro Social that noticed 30% of the population, very ill patient, has increase of ALT, ALP, or AST. This is a graphic that was just published in September 3 for Amnesty International and then published for Lancet in September 19, where Mexico is the country with where most health workers have died from COVID-19, 1,320. Next, please. Related to the liver transplant and COVID-19, the National Transplant Center suspend organ and tissue donation and transplant program since March 1 and reactivation for transplant program in August 14. Until September 7, a cumulative of 42 transplant recipients deaths for COVID-19 confirmed. And confirmed COVID-19 cases in liver transplant recipients was in 10. Next, please. And the same next, passed with digestive endoscopy, that suspension of activities in endoscopy centers was in March 14 and reactivated in July. Only emergency endoscopy were done. Currently, reactivation has taken place step by step. Next, please. Conclusions. My conclusion is the difference among the three healthcare systems are abysmal. you can hear Dr. Kelly that Mexico is in only 1/4 of the surface area than Canada, is 4 times more populated than Canada, and only spent in the gross domestic product the 5.5% in health. We have made exceptional efforts with the resources available to us. Thank you very much.
Thank you, Laura. That was a very clear explanation of the situation in Mexico and what's been happening, and certainly some of the challenges that you've been facing. So finally, we will move to the middle of North America and turn to Brett Fortune to talk to us about the U.S. public health response to COVID-19. Brett, take it away.
Great, thank you very much, and thank you for the invitation to do this small task to present the U.S. public health response to COVID-19 in less than 10 minutes. So I look forward to trying that challenge. Next slide. I have no conflicts or disclosures for this presentation. Next slide. So one would say we probably didn't do the best job in the pandemic in the United States. As mentioned earlier in previous speakers, we're closing in on 7 million cases in the US. And as you saw, as of today, we've now crossed the 200,000 death mark in the United States, which makes us #1 in both cases and deaths in the world, and top 20 per capita. Next slide. And when you look at the rate of national burden from COVID-19, it actually starts with 2 surges. If you look at both the case number and death number per day, marked by the blue arrow, you'll see around mid-March that we had our initial surge, which was associated with a very large death rate. However, the second surge, which occurred later in the summer, demonstrated by the orange arrow, shows that although numerically a much larger surge than the initial surge, it was not associated with such a high death count. Next slide. And well described in the other talks, so I won't belabor this. Clearly, the United States continues to have very high cases per million people. Next slide. And still ranks very high in deaths per million people. Next slide. So when you look at the federal and state response in the United States with the pandemic, the White House declared a national state of emergency on March 13th, which interestingly was 48 hours after the declaration of a pandemic from the World Health Organization. And then on March 16th, all states were under emergency order. And by doing so, state officials were given emergency powers that activated both emergency personnel and funds. And with the federal Congress passing of several bills, including the Families First Corona Response Act and the CARES Act, this led to basically a near $3 trillion expenditure to help provide both economic and healthcare relief to the United States. This led to support of both small businesses and local governments, protecting consumers from price gouging that can occur in times of economic distress, and adjust regulations to provide excess care to those in need. In addition, efforts to flatten the curve, as mentioned earlier by previous speakers, these were state regulations, and this led to mandatory rules for face mask use in the public, social distancing measures, including stay-at-home orders for some time, closures of non-essential businesses, and bans on large gatherings and school closures. In addition, we had travel advisories to avoid state-to-state travel, and if doing so, mandated COVID testing before it being released back into operations. Next slide. So with this, it's interesting to look at kind of over time, over the last 6 months, the state variation in the case burden. If you look at New York on the bottom right, you'll see the initial surge that occurred along with Washington State in mid-March, where we had a large surge, which then led to the national closures in all states. But however, as the surge wore off in New York and eventually reopenings, which are demonstrated by those striated green lines, we had kind of a stalled caseload in Texas, California, and Florida, which eventually led to reopening, but then had kind of a second surge, which is now where we're starting to try to recover now in the states. Next slide. So one of the concerns, of course, and Will demonstrated on the prior speakers, is kind of the acceptance of mask wearing. As you can see here, majority of the states had less than half acceptance of mask wearing, and unfortunately, there was rapid relaxation on these restrictions during the reopening phases. Next slide. So when you look at the policies focused on healthcare, the bills helped provide financial protection for all the hospitals, particularly in those high-risk states. And then there was a surge in the telemedicine utilization, which I'll show you on a later slide. And this was a result of waivers of CMS restrictions and HIPAA privacy, which would allow more tech platforms to incorporate telemedicine with all the large institutions and increase access to more patients. In addition to increased funds to rural care centers, which were obviously struggling with some of the later surges, and also trying to supply a high demand on supplies, including viral tests, PPE, and medical equipment. And unfortunately, there was probably about a 2-week deficit during that initial surge, which led to unfortunate exposures. Next slide. So when you look at the initial surge, it was kind of 2 phases. The first phase was more of an inpatient or hospital phase, focusing on closure of all non-emergent, non-essential procedures or surgeries, a massive expansion in inpatient bed capacity, particularly intensive care unit coverage with mobile ICUs or transference of floors to ICUs, and massive expansion of healthcare workforce, where we were able to graduate medical and nursing students. We were able to transfer healthcare workers from outside states with less burden to help assist those with heavy burden, and also redeployment of certain people so that we basically all became COVIDologists during this time. Then there was a second phase of trying to reestablish ambulatory care, and this was basically conversion to non-essential telehealth and gradual reopening of some operating rooms and procedure units, trying to not decrease the capacity of the ICUs, and development of standardized test protocols to avoid possible exposure to both patients and staff. Next slide. So this is an experience that we had in New York, looking at kind of the conversion of going from a basically near in-office encounter system of here basically 98% to within March and April, we went to a near 90% telehealth capacity. Which was quite an amazing feat. And then as you can see, during phases of reopening, we've started to slowly go back to our standard in-office visits, and we'll see what happens as we go into the fall and a possible second resurgence. Next slide. So what are the ongoing barriers in the United States? Well, even though we have definitely improved our access to COVID testing, we still have disparities in that access, and we need to continue to work on that, as well as the accuracy and the timing availability of results. We still have quite a way to go on the public acceptance of social distancing, face masks, especially when we try to reopen into our schools and our workspaces. And really an overall preparation for a potential second wave. As you could see from Kelly on the Canadian experience, they're already starting to see that surge. Are we expecting an even larger surge beyond our summer experience? And that could be, and there can also be additional consequences from the ripple effect in deferring medical care in our chronically medically ill patients. In addition, we need to have a really successful vaccination plan. And we can't forget influenza, because the twindemic, which has been socially media termed, is definitely something to worry about. And then we have to continue to address clear disparities in healthcare delivery to our vulnerable populations. Next slide. And on that note, unfortunately, New York City is not immune. As you can see here, looking at on the left, the median household income based on regions, you can see there is a clear correlation to the right side, which were the death rates per 100,000, that in lower household income areas, there was a clearly disproportionate death rate compared to the rest of the boroughs. And unfortunately, this can be seen in other major urban areas throughout the states. Next slide. In addition, when you think of the issues referred to patients specifically with liver disease, there's an impact of ongoing public fear. We continue to struggle to convince patients to come see us again. And it requires ongoing education and staff time to reassure these patients, meanwhile still trying to find this unknown truth of exposure risk. And therefore, this leads to substantial delays in routine testing, screening procedures, and treatment. And we're worried about this wave of severe decompensation and cancer burden, as well as the exacerbation of mental health and substance abuse. And you can kind of see on the top right a nice quick brief study published in Gastro a few months ago showing a VA cohort of cirrhosis admissions to the VA and showing compared to last year in March to this year, there is a substantial decrease in admissions, basically due to the fear. But where did these patients with liver disease go? Did they get cured? Of course not. They're afraid. And therefore, moving on, we need to accept the health systems to use a more hybrid model of including both in-office and virtual care to manage these patients so that we can adjust the infrastructure and provide adequate care, as well described in the bottom right, a nice editorial in the Journal of Hepatology from Drs. Tapper and Azrani, looking at the different ways in care and needs to treat our patients with liver disease. Next slide. Therefore, obviously, of patients with advanced liver disease and cancer, this obviously had a ripple effect on transplantation, our curative treatment. And as you can see here, not only the national experience of all organs decreasing by 50% just during the month of March, liver transplant was not immune to this effect of a decrease of 30%. And although the volumes have picked back up over the summer, and we have established national and OPO-specific guidelines on how to treat patient or screen patients, both the donors and the recipients for COVID, this clearly has led to a ripple effect and likely led to several uncalculable preventable deaths indirect to the COVID epidemic. Next slide. So what are our next directions? Well, obviously further expansion in medical insurance coverage is necessary to deal with the pandemic and ongoing chronic illness, as we're well aware in the United States. Expansion of telehealth and preventive health programs. Really important is national education efforts. We need to address these disparities that are being shown very clearly on social media and the news, that we need both federal, state, and local officials to provide a more unified single message to help convince the public that we have faith and can operate effectively. In addition, we need continued financial support for our health systems and obviously other businesses, because this has been a drastic financial strain with the closure of our more operations such as operating rooms and procedure rooms, and we need that further support in order to keep those doors open, to keep those beds going in preparation plans for the second surge, which includes making sure you have enough inventory for your equipment, your PPE, and of course your work floors. And on top of that, again, I will stress vaccination programs that are effective, including the involvement of vaccination for influenza. And then for those patients with liver disease, we need to continue to adapt our care models to ensure appropriate screening, treatment, and transplant access for those of need. And with that, I will conclude. Thank you.
Thanks, Brett. That was a great discussion of the challenges in the United States. And I think all three speakers have done a really nice job of presenting really a nice snapshot of the situation in each of the three regions, but also some of the challenges and successes. And right now we're going to turn it back to you and do another poll question. And Brett showed you the situation in his region in New York, but we'd like to know from you currently what percentage of your practice is virtual, so not at the peak, but currently, and what percentage of your practice would you like to continue as virtual post-pandemic if you had the choice? So if you could answer both of those questions, that would be great. All right, so interesting to see that we definitely see a mixed response amongst the participants, that we're seeing that some people as low as 25%, less than 25% of virtual care now, while others almost back to normal levels at 75%, or sorry, actually the opposite, I guess, 75% or more. And interesting that most people, it looks like, would prefer to have a small percentage of their practice be virtual if and when the pandemic settles down. So I think with that, we're now going to go to a discussion with all of our participants. So I'm just going to ask everyone to just turn on their videos. And we'll turn it over to Ignacio to start the panel discussion. And I'll just remind the viewers that you can submit your questions through the Q&A section now. We've received a few and we'll be addressing those, but you can continue to submit them as we go.
Thank you, Jordan. I have a question for Dr. Cisneros and Dr. Burek regarding telemedicine in your practice. How has your practice shifted in terms of telemedicine?
Telemedicine is not a new concept. It was used first time in the 19th century in the US Revolution, when a doctor in the battlefield has to call via telegraph to another remote doctor to say to amputate or not a patient. And now it's new for us because we have never used it before. And but we have to adapt with the tools that we can use. And with this pandemic, we have to add to our private consult or our practice this new modality, and we can do the televisit, see the symptoms and signs and symptoms of the patient, to teleinterpretation of the labs, and teleconference with the rest of some doctors to see which is the better treatment for the patient. For me at the beginning, in March, we have to use the telemedicine in 90% of the patient, but now it's a little difficult. The millennials accept the telemedicine very, very simple with no problem, but the baby boomers is very difficult to accept them, and they prefer the face-to-face consultation. And now in my practice is around the 20 to 25% of telemedicine, but telemedicine came to stay because it's a very good tool.
Thank you. Dr. Burek?
Yeah, I'd say right now, probably my own practice is about 50-50. Telemedicine in person for my clinics. I agree. I think it's here to stay though. Canada I showed, is a big geography and spread out, and a lot of patients have to travel long distances to access specialists, including liver specialists. So, even our transplant program accepts patients from 3 or 4 provinces in Alberta. So one of the challenges is during COVID, this has been freed up, but going forward, I do not have the ability to see a patient from another province without getting a license to practice in that province. So it's going to be a challenge for some of those patients, but I think it's here to stay. And the experience is the same I've had with the older patients. Surprisingly, some of them like Zoom meetings, but there can be challenges with technology.
Okay, I would like to ask Dr. Price, do you think these changes in telemedicine are going to persist after COVID-19?
Yeah, I echo what the others have said. I think the telemedicine is here to stay, and that it'll, the balance will be a little bit different. We'll probably be doing less than 50% telemedicine, which based on the poll response seems to be the preference of the majority of the attendees. But I do think it's here to stay. In our practice, our patient satisfaction rates are actually really, really high right now, better than they were pre-COVID. And there could be a lot of reasons for that, in part because people are worried about coming in and appreciative of being able to see their providers remotely. But I have several patients, including the baby boomer patients, who were really reluctant to do telemedicine prior to COVID. At UCSF, we were early adopters, so we were doing telehealth before the pandemic. And I had mentioned it to them before because it would come from so far away for these clinic visits, and they had no interest. And now they're telling me, after the pandemic, I'd like to continue this because now they've gotten a handle of it and they realize how convenient it is. And, on the provider end, we're right now formally evaluating the provider satisfaction and the staff satisfaction. It's been a lot of work on our staff really to educate the patients and kind of coach them through the Zoom. So I think it has been a big burden, but the providers seem to be pretty satisfied. It's given us a lot of flexibility. And we also are, like Kelly said, we're able to see patients from really far away. And I think it's actually a really good opportunity to expand access to our specialty care. So I'm hopeful that when we're on the other side of this, we'll have some sort of hybrid model like what Brett described in his talk, and that we won't be using telemedicine just out of necessity, but we'll be able to use it to really expand care and to innovate.
Great, thank you.
So one question came up in the Q&A that I wanted to pose to Kelly, and that was, are you concerned with the lack of development of herd immunity in Canada?
Yeah, it's a good question. There's been some seroprevalence studies performed in different jurisdictions. Canada just recently did one on our blood donors, and our rate of positivity across blood donors, which tend to be healthier people, so it might be a bit of an underestimation, was probably around 1%. So in some jurisdictions, like where Jordan works, in Ontario and Quebec, it might be in the 2 to 3% range in the larger urban centers. So still very, very low. But herd immunity, my understanding is that this is a concept around vaccination, and to get 80% of people having herd immunity because they've been exposed to the virus is going to cause an enormous amount of deaths and disability. So herd immunity is really, something around vaccination. And that ties in a bit to, something that we might discuss later is about acceptance of vaccine when it actually happens.
It leads into a question, Kelly, that I was going to ask, and I'd actually be interested to hear your thoughts and maybe Jenny's as well, but about whether you think what the impact you think has been on the acceptance of science and people's understanding of it and acceptance of experts, which I think has been a challenging issue and really created some challenges in the different countries. So I'd be interested to hear the perspective in the US, Canada, and Mexico.
Yeah, it's certainly been a challenge. As somebody that runs a continuing medical education office, it's also been an amazing opportunity. We normally have about 4,000 docs come to our offerings in a year, and we do Wednesday evening webinars on COVID, and we've had over 8,000 attend so far. So the science is changing so fast, the information is changing so fast that it's really hard to stay up on what the latest information is. And that's led to some problems, and I think that's led to some mistrust in science in general. When you see all these pre-publications, you see big studies in reputable journals being pulled back and withdrawn because of concerns about how the studies were done. I think it does harm, it does harm. And then the other issue, I think, is, science is, the scientific method means that things will change, and what we believe one day might change based on new evidence. And our public health, I said our public health officials are rock stars, but they have received criticism around things like masking. Early on in Canada, they weren't very keen on masks. Later on it became clear, and people saw that as a flip-flop. Well, that's not a flip-flop. That's actually, how science works. So, I'm a little bit worried, the public has missed, we've lost a little bit of trust. I'd be interested to hear about Brett's perspectives in the US.
Yes, no, it's been a wild time, especially in the first 3 months of the pandemic, and definitely trying to deal with the media as well as obvious politics that were going on, and still trying to keep the trust of the public was quite a challenge. Again, the fear of convincing people to see us, because we were considered basically a COVID world headquarters for some time, and then all the news showing kind of the inabilities for healthcare to keep up did not help us. And on top of that, regarding your questions about science, it has definitely been a challenge because although I give our system a ton of credit, there was a huge investment in trying to make it as standardized as possible. It was a centralized research team that was in charge of the clinical trials and recruitment registries. And we made this very valiant effort, which is, I thought, is about as clean as you get. Obviously, when you deal with the news media and people with influential voices making statements, it makes it a challenge. And to tell what is the truth versus, for lack of a better term, fake news. And I'll probably stop there before it gets too beyond the political movement here.
Yeah, regarding Mexico, we were a little slow to really grasp what was going on. Our government was a little skeptical about everything that was going on in the world. And that, of course, is reflected in the numbers, both in the number of cases and the number of deaths. Mexico has a very broad spectrum of medical care that goes from basically nothing to pretty sophisticated care, depending on where you are and who you are. And that has really caused a lot of distrust amongst the population. And unfortunately, as physicians, we are forced to work with what we have, which in a way is a little bit of what's going on with the use of off-label medications. I'm sure a lot of people were a little surprised about what medications were still being used. There are hospitals that are still using hydroxychloroquine as the only single treatment for COVID, although there is really no scientific basis for their use, no proof. That is pretty much all that they can provide the patients. With regards to PPE, the same thing happened. I mean, we were really very slow to protect our healthcare workers, which is one of the reasons why we have this large amount of healthcare worker deaths.
I had a question just to follow up on that for you, Ignacio, as well as Laura. Is the striking number of healthcare deaths due to COVID-19, is that because of the PPE issue? Was that earlier in the pandemic? Are you still seeing a lot of healthcare related illness and death today?
Yeah, I mean, these numbers, 42% of the deaths were nurses, 27% were physicians, and 31% were techs. And there was a lot of deaths amongst the cleaning personnel in the hospitals. Unfortunately, most of these cleaning personnel are outsourced. So it was a while before they were properly protected. Fortunately, things are changing. The resources are being channeled to PPE, which we hope will change these numbers. But there's reports that between 7 and 12% of COVID teams were infected during the first months of the pandemic.
And now around 60% of this population was doctors, and these doctors has to work in 2 or 3 different works because the low incomes. And in each hospital that he exposed to the COVID-19, inside of the COVID-19 center or place, they increased the exposure, 12% rate of more infection disease. And when there are a recent report from the 2 public more important institutions, Instituto Mexicano del Seguro Social y el ISSSTE, and they say that these doctors that died was associated with comorbidities. First, the obesity. 70% of them has obesity, 40% has hypertension, and 31% has diabetes. And we are the second country all around the world with obesity. This is the reason that they have to work more. They are exhausted physically and emotionally because they have a stress about he's going to be contagious for them and the family. And all these things all together makes that the deaths in the healthcare workers are higher than the rest of the world.
Maybe I'll jump in with another question, sort of just shifting gears a little bit. What have you seen in terms of the effect on research? I mean, obviously, people are a bit reluctant to come to healthcare settings, and there's risks around that. So I don't know, Jenny or Kelly, if you want to tackle that and just see how that's affected recruitment to studies, finishing studies that were already going, and do you see that ending, the problems?
Yeah, I guess I can start. I mean, we have a fairly active clinical trials unit at our university, and initially everything was shut down. There was a question that was put in the chat box about access to liver biopsies, for example, and how that was affecting clinical trials. So modifications had to be made in protocols, and as we saw that our initial peak was quite low, and we were starting to reopen, at the same time the clinical trials started to be open. But a lot of the follow-up, in our own center was virtual for a couple of months. And so, the patients weren't getting physical exams like, per protocol in a lot of our studies. I think it'll be an issue as, if we don't react properly to the trend in our cases in Canada right now, they're talking, there's a lot of reluctance to lock down the way we locked down before. And so there's going to be, probably modifications performed all over the place. We're starting to see that locally in different jurisdictions in Canada. And so that might, again, depending on where the hotspots are, affect trials.
Yeah, and I'll just say from the US perspective, I mean, it's had a tremendous impact on clinical research. I mean, everything went to a halt for a while. Things are starting to open back up, but it really depends on the region and the center. And I think a lot of centers are struggling with trying to come up with their new protocols to allow for research to continue, but in a way that's safe for research participants. I'll put in a plug for a prior webinar that the ASLD put on that really focused entirely on this issue. It's available on Liver Learning and YouTube if anybody's interested in further discussion about the impact on research. But I agree with Kelly. I think it is going to last a while. And it's also been particularly challenging for the multi-center studies because across the United States, as Brett described, there's been these waves of the pandemic. So one area might be opening up and another one is hitting their surge now. So it's been very, very challenging in terms of planning.
I work in a research center, and we can saw that we have decreased around 20 to 25% of the people that want to continue in the research because they come from all around Mexico and they are scared if they have exposed or not. And certainly it has affected research trials. We have to wait maybe 2 or 3 months to reopen in the same condition that we used to have.
So we have another question that's come in through the chat. International registries demonstrate that patients with liver diseases have a higher mortality. The methodology of these studies could cause an obvious bias of selection. What's your opinion about this? And should we say to our patients that they are at higher risk? What measures might we recommend? So not sure who wants to field this one first. Maybe Jordan?
That's a tricky one. Yeah, there's no question that the registries create challenges. Obviously, there is some selection bias in who's enrolled, and the data need to be really carefully interpreted. And that's not exclusive to liver disease. We've seen that in inflammatory bowel disease, other areas of GI and hepatology as well. I think it's important that these studies are done. Some ways you can get around it are by having people that report bad outcomes have to enroll a certain number of people so that you try to get some number of consecutive cases, but it still has to be taken a little bit with a grain of salt. And I think we have to be a little bit prudent about what we're advising people. And the types of advice that I've been giving people are that it doesn't really seem that liver disease per se increases the risk of getting COVID, but for people with more advanced liver disease, if they get it, just like getting influenza, frankly, can tip them over and take a compensated cirrhotic and make them decompensated, or take a decompensated cirrhotic and have them end up in the ICU. That is true with COVID. So there are recent reports that the virus replicates in the liver. And that's probably true. And certainly we see liver enzyme elevation in a lot of people. But I think for people without cirrhosis, the risk of liver failure or serious liver-related complications is probably pretty low. But this is obviously still an evolving field. I'd be curious to hear what others are telling their patients.
Maybe I'll jump into that very similar advice. And I think the same holds for our immunosuppressed patients. There doesn't seem to be a huge signal that they're at increased risk of contacting the infection, and tell them that they all have to pay really careful attention to the physical distancing and public health recommendations, because if they do get it, there is a signal that they may have a worse outcome. So, that's the kind of advice. And it's, I think one of the things that is really complex is, as kids go back to school, what do you do about this is the question that's coming up all the time, is should I be keeping my kids home from school because I'm a immunosuppressed liver transplant recipient? That's a really tough one, and you have to balance all the other good reasons that children need to be in school. These are really difficult conversations to have.
You think we'll get good data at any point, or are we going to end up with a sort of muddled registry data we're not really sure, or is there going to be more of a definitive answer to these questions?
Brett, for you.
I think definitely over time we'll be able to get to the true denominator, which I think was an excellent point made by Jordan. These registries clearly have bias. It also is through academic centers and not involving the community, which, if the community mortality was even higher than the academic centers because they had the infrastructure. Whereas in New York, we had primary and community hospitals really struggling with extremely high death rates because they couldn't handle the volume, and those weren't accounted for in any registry. So especially if they were outside our health system. So I think time will tell. Obviously, we have several data sets that come out on a timely basis that take good subsets from multiple hospitals as well as care practices. So I think time will tell, but it probably is going to be a while before we truly know the true impact of this virus, let alone the economic impact, which I think is exponentially on a global scale unheard of.
That was actually an interesting point for me in terms of the differences between the healthcare systems, that the striking effect that this actually affects for-profit hospitals in a negative way, whereas in Canada, where all of our hospitals are public, shutting down the hospitals and reducing our capacity was really a health saving, at least before the surge. And so it was interesting for me to hear you mention, Brett, and I'd be interested, Laura, if that's also been an issue in Mexico, that the private hospitals have been trying to maintain people coming into their ambulatory settings really to keep revenue churning. And if actually any hospitals have gone out of business because of a pandemic, I'm curious if that's happened.
Well, actually, what was done in private hospitals in Mexico is that some of them tried to be away from COVID. There's a large group of hospitals that assigned some of their hospitals for COVID patients, and the other ones were labeled COVID-free. So not surprisingly, people much rather would go to a COVID-free hospital, although I don't really think that exists, to have elective surgery or endoscopy done and try to stay away as possible from these COVID positive hospitals. Hospitals have thrived. As a matter of fact, the government had a contract with private hospitals that expired on May 23rd. So it went on from mid-March to the late May, where they would actually pay private hospitals for taking care of COVID patients. So they did thrive, and no hospital has really suffered from the pandemic down here.
I have a somewhat related question. Brett mentioned the downstream effects that we worry about, at least in the United States, of the pandemic with the economic impacts. We're very worried about people who have lost their jobs losing their health insurance. And I'm wondering, in places like Canada, where such a high proportion of your patients are publicly covered, is that also less of a concern for you?
Yes and no. As I tried to highlight, I still think, although we're publicly funded, still some of, medication coverage, especially expensive medications, a lot of it happens through private healthcare insurance. And there are ways to sometimes access coverage for medications through different plans and things. But that takes time, and we know how expensive some of our antiviral treatments are. We have seen people lose their job, lose their medication coverage, stop their hepatitis B treatment, for example, and experience flares. So it will be an issue for us, I think, in accessing hepatitis C treatment. For some people, or at least delay it. Jordan can maybe.
Yeah, I agree to a certain extent, Kelly. I think the thing is we're protected from the because people still have their primary healthcare coverage. So for outpatient and inpatient care, they still are covered, and that's pretty much universal across the country that people will all have insurance. Kelly's absolutely right that for medications that's not always the case, but in most settings, there's a pathway to get coverage publicly funded for medication. So it's really, and I think it's something that's our job to make sure that when people are falling off that, that ledge, and they're potentially ending up in a situation where that's going to happen, that we make sure that like we did, for example, with our hepatitis B, we have a large population of patients that were getting their medications through private insurance. And I would say we recognized that pretty early, and we made sure that everybody could transition to the public system if they lost their private coverage. So I don't think we've had any catastrophes there, but it's certainly something we have to be watchful for.
And I think the other second wave that we're really seeing, I'm starting call tomorrow, and I'm sure it's going to be, like every other week that I've heard about from my colleagues that I share a call with, the hospital wards are full of patients with alcohol-related liver decompensation. And the severity of alcohol-related liver disease that we are seeing, and severe alcohol use disorder in young people, is staggering. And I think this is, we're just seeing the beginning of this. And the harder the economy gets hit and more people lose jobs, this is just going to be worse. I'm sure that's the same in the United States and Mexico.
We've seen similar things with increases in injection drug use, more overdose deaths, and reported really across the country in Canada, and I think that's true in the United States, and that likely signifies increasing incidence of hepatitis C as well. So certainly lots of spillover that are not directly related to COVID and its effect on liver disease. We're wrapping. We've gone just past the hour, so maybe I will wrap up. And maybe Ignacio, do you want to just?
Yes, I would like to thank our moderators and our presenters for a wonderful talk, and I want to thank everybody for joining us today in the COVID-19 and the Liver in North America webinar, the impact of contrasting healthcare systems. We are thankful for your attention, and as we discuss the different approaches from all three countries, we all belong to the same region, but as we could see today, our medical care is very, very contrasting and very different. So I think it was very enlightening to see how things were dealt with in North America. We appreciate your questions and remind you that this webinar will be placed on the ASLD Liver Learning platform and the Liver Resources page for on-demand viewing in the next few business days. Thank you very much.
Thanks, everyone.
Thank you. Thanks, everyone. Bye-bye.